This is a Change Physician, episode 164.
Hey, folks, welcome back to another episode of the Change Physician podcast. As your host, Dr. Kevin Cuccaro, with Dr. Melissa Cady, the Amazeballs co-host herself. Melissa, how are you?
I'm Amazeballs.
You're Amazeballs. That's awesome. Because we want to have an Amazeballs episode here. Okay. And really what I want to do is probe a little bit more into what you do and how you do it. And the reason I want to talk about this is we talk about entrepreneurship. We talk about mind shift shifts. We've been interviewed from amazing people who have done a lot of things, doing from crazy different ways. I've always been a pretty heavy proponent on direct primary care, which I think really kind of returns the practice back to this physician-patient relationship. It serves them better in many ways. And I've always been very interested in seeing that because primary care docs historically have had the short end of the stick in most healthcare systems. Direct primary care kind of flips it on its head because now they're kind of back in control, and they can, in many cases, make more money and have a better life balance and have better patient relationships. But as the anesthesiologist and pain guy, I've always looked at it and go, oh, well, how do you do that? Like, how do you do that? And I've figured out some methods that actually don't serve the patient really well, which is why I wouldn't talk about those ever. But what I've never heard and never seen is how to do it in anesthesia. Anesthesia, for listeners who may not be physicians, as we talked about in another episode, we have many different masters. Typically, the group will be either employed by the hospital system or at least contract with the hospital system. And so there's this super weird relationship where, you got the hospital that you got the contract with, you got the surgeons on one side who you're dealing with and kind of see you as a service, and you're sort of trying to make sure that you're optimizing them while they don't kill anybody. And then you have the patients. This is a very, there's sort of this misunderstanding that that anesthesia doesn't have direct patient care, and is the stupidest thing ever. We have to go in where people are extraordinarily stressed out and build a rapport and help them to feel safe, oftentimes within 5 minutes. If you don't have good patient skills, sure, you can do the job, but you're not going to do it as well as you could otherwise. So kind of a challenging place. And I could never figure, well, how would you do direct anesthetic care? And Dr. Cady has done that. So let's start a little bit here. Is what was your background? And then what brought you into where you are now, where you're actually doing what is basically direct anesthetic care?
So let me just say 2009 for context. I finished my pain fellowship, chose not to do pain. That's for another episode, but went into doing general anesthesia. Actually, I did that part-time, like little locums while I was in pain fellowship. So I was still holding on to some of the skills and decided not to do pain. So I started out not full-time because I was still trying to figure out if I was going to put pain into my life in the world of medicine. And I found a place in Austin where I could just do 2 or 3 days a week. And then after a couple of years, went to 4 days a week so I could have better benefits and better pay. Well, 9 years down the road with that group, actually throughout that course, I'll just essentially say I learned a lot about the frustrations of being an employee. And it's not necessarily directly targeted at my group, but there is a certain sense of lack of autonomy that you have just as an employee in general. And I found some things, we're just used to doing things the way we're doing things all the time. You go through training, you just see the patient right before you go back to the operating room. And then I'd see these surgeons that like already built a rapport because I at least seen them once beforehand. And, but yet we remain with the stress of like keeping the surgeon happy, keeping the whole operating room happy, the staff that don't want to be there forever, and being efficient. So that's the biggest frustration, is the balance between safety and efficiency, or speed and safety, I should say, because efficiency, if you are efficient, that means you're actually being smart about the safety part and incorporating whatever time is necessary, not anything extra. But anyway, that's another topic too. So I ended up leaving that group at the end of 2019. Scary. It was kind of one of those, we both mutually agreed that we're not a good fit. And I moved on and jumped in the world of locums. And there is an autonomy there, but the traveling to another state and having to get credentialed and go through the whole licensing process, that just adds levels and levels of stress that you're used to in a way, but it's not really wanted. So then pandemic hit, stopped my locums pretty much around March, had been around that time asked by one of the surgeons I used to work for. So never burn your bridges and just take care of patients well, and people will notice. And so I was asked, I said yes. The other surgeon, who actually went on his own way too, so they initially were together, now are separate. So that brings us up to the current state where I am independent and helping two surgeons, which I think is actually, if you don't have enough load money-wise in one, I think it's nice to have two in case one's on vacation or sick or whatever. So that's where I'm at.
So let's pause there a little bit, because there's a couple details to unpack. And one of the most important details here is for what you do, and to kind of direct this, you have to choose the right population to serve. Yes. And what I mean by that is the surgeons that you had contacted you and worked with were plastic surgeons. And the reason that becomes very, very important is because plastic surgery is predominantly elective and cash based, which provides a freedom when it comes to some of the billing concerns. So you have those relationships now, and you have the surgeons that you're working with. So what was the next thing that you kind of did?
So they asked for my fee schedule. That's actually really hard. When you've been an employee, you have no clue. All you know is the market for what you will likely get paid if you were hired as like a locums or a fill-in, or and do you want me to talk numbers, or you want me to just kind of just jump?
I think you can talk numbers. You can talk numbers.
Yeah, I think anesthesia people might be interested in. So there's quite a range of things, and depending where you live, I would say Austin doesn't pay as well sometimes as like Houston or Dallas, and so it all depends on geography and your region. So many times when you want to do locums, it could be like 150, 200 an hour, something like that. Some places 250, 300. It just depends. Are these insurance cases, or are these like higher paying like cash practices? Now, what we haven't talked about, which is a dilemma of anesthesia, is that CRNAs or nurse anesthetists are now starting to get offered pay that is comparable to anesthesiologists, depending on where they're going. So like East Coast places, and people, and anyone that knew the inside scoop on different places. So I had to like figure out what I would be okay with, and then I present it to the surgeon and figure out if this is like reasonable, because they have to sell the surgery, which they have to give the whole quote for surgery center, me, and the surgeon. So it needs to be appealing. So initially they didn't really know fully the process I was going to develop, and so at first it was just like, okay, what am I going to charge? And then you think, well, some of my time spent there is not just the actual anesthesia. It's like between cases, if I'm doing pre-ops, which I did know I wanted to do pre-ops ahead of time, regardless of the pandemic. So what's that time worth? So I had to like, in my mind, create what made sense. So, and I didn't know what kind of volume.
You also have to build in for somebody who's really just starting off. The other thing you have to, because there's a risk of lowballing this stuff.
Yes.
Because so you're looking at locums rates. Well, that's not including what the locum company is getting paid.
Exactly.
And you need to make sure you're remembering that. And then the other thing is, when you're in sort of any sort of freelance or that kind of role, that hourly rate, or if you're thinking in an hourly pay structure, you got to remember you have to now bill in your insurance, your medical care, like all those little things that if you were an employee would be built into your benefits package. You got to incorporate that now into basically your charge sheet. So,
right.
And I just wanted to make sure people are aware of that, because otherwise you could totally lowball yourself and cause a little bit more difficulty than you need.
Yeah. So I'm not going to say exactly what my fee schedule is for confidentiality, especially amongst my surgeons and other people. I don't know when they're going to watch this either. So, but needless to say, I would say that the first hour I basically build in, because you're putting so much effort. If it's a 5-hour surgery versus a 1-hour surgery, I need to make the bulk in the first hour. So I made my first hour like almost at least double of what my hourly rate, because in anesthesia, we're weird. We have like, if you're billing insurance, it's like you code for the type of case and then the time added to it. So I basically knew that I was going to be putting more time in on the business side or the pre-op side, and I want to make sure I got paid for that. So every patient, the first hour is the bulk, it's kind of like an augmented price for the first hour, and then everything after that's like a set rate.
Yeah.
So that's how I built it. That was the first thing I had to do, and they had to be okay with that. Funny thing is, 1 year later, they recognized the value, and I went ahead and increased my prices. That's the beauty of being your own boss. So.
Well, and that's something that you should also be considering too, as price rises and they're increasing their prices as inflation changes, then you need to be able to do that as well. So do you have like is it a year contract for those things, or like do you have a year, basically your charges for the year, and then you kind of just let them know that these will be under consideration in 2022 or 2023 or whatever?
Yeah. So my recent increase, I stated at the end of this year. So I started in the middle of the year, and so I wanted to push it to like a regular financial year. So I said that this new rate will stay in effect till the end of this year, because I increased the prices like midway last year. Mm-hmm. So that's how I did it. But that was the initial like stressful question mark for me, is what am I going to charge? And it is like you're like, where do I start? Like, how do I even know? Like, the minimum because of what you've been used to being paid, but that didn't make sense as an owner. Mm-hmm. Yeah.
And as a physician, I do think a lot of us tend to undervalue. I mean, particularly you brought up this stuff with pandemic and this, I don't want to say pay parity, but when you're looking at what people are getting paid who are not physicians, physicians really need to know their value, because it's ridiculous, absolutely ridiculous what's getting charged out there. And it's because we don't recognize it, and we don't support it, and we don't promote it.
Right. And the lack of enough physicians do it, that's why they're reaching out to other people as well. I do have friends that are nurse anesthetists. I actually 1099 a couple CRNAs or nurse anesthetists from time to time, because I know they're strong CRNAs. And I tell them, I hate the turf war we're in. I think I think we all make a choice on what avenue we go, and that I feel all of us should be valued and that we should be paid our worth. But there is a line you have to draw if we take different paths to say, well, what's the point in going to medical school, if you're going to get paid the same as a nurse anesthetist versus like a physician. So anyway, that was a little side note. So I am very generous. I am very generous when I pay my CRNAs, because I do want them to help me out when I want to be helped out.
So, you want to be a good employer.
Yes. And I do not have employees. That's very important to me for a lot of reasons. So
you want to be a good contractor.
Or I'm contracting them. A contractee? I don't know.
Contractee. Yeah. Well, whatever. So that you don't have you're not paying them
all the legal responsibilities of.
Yeah. But that's an important point too, because if you're anything like that, we complain about whatever environment that we're in, and maybe our boss or the health system or structure, if you treat people fairly, they tend to do good work versus the micromanaging garbage that typically goes on in healthcare, where people are not being treated like adults.
Right. Yeah. So you asked about the date and like the contract. I do create like a Google document, and then I do send it through like a DocuSign kind of program, or Signaturely, or there's a lot of them out there, and have them sign it. And then it's kind of agreed upon contract. And so, but it's just more for legal purposes to do that. I feel like I have a long-standing relationship with these people, but it's always good to have it in written.
Definitely have it written.
Yeah.
So you're working then predominantly out of a surgery center.
Correct.
Okay.
Which is an issue from okay, go ahead. Sorry.
No, I think that's the other important point, is the practice environment that you're in. You're working with specific surgeons who are doing predominantly cash-based services, and then you're going to be in a surgical center environment. So I'm going to let you take it from there.
Yeah. So one thing, it is predominantly cash practice, but the most important thing at the very beginning which ironically, I was already getting credentialed with insurance companies directly. Something people don't realize, if you've been employed and then you go on your own, but yet they were billing under their group, you aren't necessarily directly credentialed with the insurance companies. And so it's really important to know that just because you've been doing work on, Blue Cross Blue Shield patients, it doesn't mean you're credentialed directly. And so if you're going to be your own entity, which that is the important part there. So you have as a physician, you have a NPI number, which is National Provider Identifier.
I think that's
I can't
right.
remember. Yeah, there's an acronym for that. So you have that. But when you want to have your own business, highly recommend creating an LLC or some other, you can talk to your own legal consultant or accountant or whatever. Create your entity. I use an LLC, but you have an EIN number that is a federal number that identifies your, as an employer, I guess, EIN, employer identification number. Is that the acronym? So I have an EIN, but I've had that for a while. So when I apply to get credentialed with insurance companies, you need to get that ball rolling. So I'd already had that ball rolling, but you have usually a second NPI for the entity. So this gets really confusing, and it's really critical if you actually hire people that you might be billing for their services under your business. You don't want it under your rendering NPI as if you were physically there. So there's a lot of things there you got to really kind of nail down from an insurance standpoint. So like I said, 10 to 15% of my stuff is insurance, and you really need to get that figured out. You also have to figure out, are you going to have someone do the billing for you, which I think the going rate is anywhere from like 5 to 7% that they will take of anything that you bring in, that they will use as what you pay them. I found that I got frustrated with the follow through with the particular company I was with. And I'm sure there's a lot better ones, but I don't have enough volume for me to substantiate in my mind when I can personally follow through. So I found a company called Trizetto. It used to be Cognizant, but they have a simple claim process. So literally I can just take the information. I can be a complete naive insurance claim person and just enter the data and submit the claim through what's called this Trizetto clearinghouse. It's a clearinghouse, which then shoots it out to the insurance companies that you're credentialed for. There is one I'm out of network for called Aetna. They don't allow anesthesiologists for some reason in my region to be directly credentialed. So I can just submit it out of network. But an interesting point took me a while to figure out is that if the surgeon's a network, the surgery center's a network, they've approved the surgery, they call it an enhanced claim because they know anesthesia is along for the ride. So even if you're not in network, I've never had them not pay. So just a little side note there, is kind of a relief that if I do have someone working underneath me, like a nurse anesthetist, they can do that out of network one. And I can put in there's certain codes so that the CRNA did it only. But since I'm out of network and I don't have the contract with them, I can get paid out of network for that CRNA helping me.
It just makes me laugh because you're like 10 to 15% of the cases that you're working with are insurance, and this is a majority. It sounds like of most of the paperwork is for this 10 to 15%.
Yes.
To try to get this stuff with the insurance company. So
yes, let me make a note that I have just recently got paid almost a year, which that year is a critical time period, from a Medicare patient that I had communicated on 6 different occasions with my prior billing agency company and followed through with Medicare, and like still having, it is a nightmare. I'll just say it. I hate insurance. I despise it because I don't think it works for the patient, because it's not. It's not where the bottom line is really trying to be met. Anyway, I'm very biased because of the frustration I experienced, but yeah.
Well, so that's like, again, that's a 10 to 15% that's yep. Sucking up like the majority of the time. Let's focus on the 90% though.
It's beautiful.
And that's the important part, right? So the 90% where you're working with these surgeons, this is cash-based direct patient care for anesthesia. Mm-hmm. And so how does that then work? Like if the surgeon's initially presenting the package to the patient, how do you get involved with the billing, and how are you collecting, and
Right.
What are you doing there?
So I have an agreement that whenever they schedule or when they're ready to send me the scheduling sheet, which they put the quote of what is on my fee schedule, so I know what they've been told. So we keep the situation. There's been a rare occasion where they looked at the wrong line and told them the wrong thing, or and so I either agree with that or not. But they'll send me the information as soon as I get the information. If it's within about 2 weeks, no more than 3 weeks ahead of time, because a lot of times there's these arrangements that they can get a full refund if they cancel at least 2 weeks in advance, something like that. So I try to keep it closer to like 1 or 2 weeks in advance, definitely within 3, unless someone's requesting to talk to me before they even schedule. So I will send that. I have my notes on on any Mac device. You've got these little sections for notes. So I actually have a pinned note that has all of my predetermined like text messages, like, I just received your information from this doctor so-and-so, and this is what I expect to do an anesthesia consult. It's all about you and what to expect. And so to answer your questions, please feel free to schedule at this link. And if you have any problems with scheduling, please let me know at this number that I just texted you from. I send that to the patient. They either text me back, say got it, or they think it's automated on some occasions. It's good to write, just say this is not automated. And then, I'll end up just submitting it to them and we get it scheduled on the books. And I end up doing a reminder in the form of please watch this video to, regarding the play-by-play of what to expect the day of surgery before we meet tomorrow. And then that'll trigger them to remember we have the chat. And after the chat at the end, I even say at the beginning of the chat, because some people want to talk money, I just say, okay, I just want to go through your medical information. Thank you for watching the video. And I want to answer all your questions so we don't have to do it the day of surgery. Of course, people are very relieved by that most of the time. And I said, and as far as payment, I'll tell you how we do that at the end. We won't be during the call. It'll be done at your convenience online. And I'll tell you at the end how to do that. That's literally my spiel at the beginning of this. And then I just send the invoice via QuickBooks to an email. But I also will send from my notes, a pre-written text that I fill in whatever I need to fill in for that particular individual, and just say, here is the link for your convenience. If you have trouble finding it in your email, business name, Painless Wellness, Anti-Pain Lifestyle LLC, just so they can recognize it. And then right after that, I have a pre-made preoperative instructions that they can refer to the day before so they don't mess it up. And so I text that too. So it's all done, boom, boom, boom. And they can always reference that phone number and they have access to me anytime.
So do they pay prior to the operation, or do they pay after the operation?
Sorry, good. I didn't finish with that. So I tell them, you can pay, I'll send this to you after our call. You can pay anytime between today and the day before surgery. If I don't see payment the day before surgery, I'll send you a text to remind you for payment. And
excellent. Everyone's
usually really good. I've only had 1 or 2 that it turned out that somehow I missed it and they need to pay that morning, but that's too stressful. I mean,
yeah, but I think that the important part for this is, so unlike in a direct primary care where they have a subscriber model, this one you're getting it's paid per client, and the pay per client in this scenario, and it makes sense to get paid prior to the surgery being done. For a lot of for psychologically, there's a whole bunch of different reasons. People pay and then they get the service. It's unlike a restaurant where we eat and then pay at the end. Sometimes it becomes very difficult to get people to pay for medical stuff afterwards.
Can I add one thing?
Oh, absolutely.
So insurance, I've learned this the hard way. It's taken me a year to do this. So lessons. I was submitting claims. Usually I might wait a couple weeks to kind of let the surgery center submit theirs. So in case there is a deductible, it's met already. By the time my claim gets processed through, so that I get paid and the patient doesn't have responsibility, hopefully, unless there's a co-insurance or whatever. I've made the mistake that I would submit the claims for them and then find out that they did not meet any of the deductible, especially if I sent it too early. And then I have had one person in particular completely went ghost. And so I spent half of my day of my life taking care of someone who didn't really, the problem with insurance is that they assume it's going to be covered.
Mm-hmm.
Especially young ones don't understand how it works, and not all of them, but definitely some young people don't understand this yet. And there's this there's a disconnect between the value you're providing. And so that's, I think, the biggest dilemma of insurance, because they're behind the curtain. You're not really doing an exchange of value with the money and whatnot. It's just all this, like someone buying you dinner and you just get everything you want. You think everyone's going to be paid for. I mean, I could go on and on. But so this particular scenario, I've designed a prepayment policy. So I tell them that this is the range, because our work is based on time too. It can range from, $500 to $1,500 or something like that. And I pick a middle of the road number. Some people say get paid ahead of time for all of them. Like, I don't know how much. I mean, it could be a nose case goes 2 hours versus 4 hours. And I'm trying to be reasonable. So I have them, I pick an amount that if they went ghost, I wouldn't feel like I was totally taken. Mm-hmm. So I have them prepay me a certain amount.
Deposit. Place a deposit on your service.
Like a deposit. Yeah, I basically say prepayment for anesthesia care. And then there's a stipulation that states specifically, if you owe less than this, you'll get a refund by check. Actually, I'm starting to use Venmo because I have a business account and I can make it private so it doesn't show up on public feeds. So I give that option so I don't have to send it in the mail and it get lost or whatever. So, or if they owe more, they know that they're going to get another invoice and have to pay that. But it won't seem so big. The psychological component to that is that they will fight the insurance companies faster and more than me if I have any issues. And they come back to me when they want their money.
Mm-hmm. Yeah. So
the accounting is, it's a little bit more complicated and tedious to do it that way. But I would say that it creates a protective measure, and it does keep it more of a steady flow from money coming in revenue wise. And then, it all evens out. Like if they pay a certain amount, then I just dish back some back to the patient.
All right. Well, I just kind of do a brief summary here for this kind of direct practice model. When it comes to anesthetic care, one of the couple of key things is to find surgeons who are doing cash-based procedures. Majority of those are going to be plastics. Make sure you have a good relationship with them. We had talked about in a previous episode on how you can optimize your time and increase kind of your value to your patients as well as their surgeons. And that was in episode 63, I think. 163. Contracting, we sort of get given the kind of the nuts and bolts of how the ideas around how you could potentially set this up as an anesthesiologist, which is huge, folks. If you're thinking that you're feeling trapped, and particularly if you're, the other advantage of this, if you're in a large metro area, a lot of things about medicine, if you want to have a better life, you have to go outside the metro area, but there's not a lot of plastic surgeons in the middle of nowhere. So this is actually optimized into places that are generally higher quality or high cost of living, or generally are kind of so saturated. And I can't think of a surgeon out there that would hate or would not like to have an awesome, dedicated anesthesiologist that's involved with their cases.
Yes. Yeah.
So the final point here, what is your life like now that you are working for yourself and sort of set this up? Like, and specifically, don't absolute numbers, but just kind of general ranges of your income now as compared to what it was when you were employed, and then your hours and your overall life satisfaction.
Definitely love working only 10 minutes away from the surgery center. Of course, that could change. Or 10 minutes away from my house, what I meant to say, at the surgery center. The lifestyle is so much better because I do not take call. That's huge for anesthesia. That's like almost unheard of. I consider myself still part-time. So my liability insurance, actually, it's set up for a part-time. That's another thing you have to kind of deal with, is make sure you're set up with that. And you can use it a lot of times, check with the policy if you need someone to replace you. That is an issue. I think, pros and cons when you think about that. I love the lifestyle I have. The hard part is making sure that your system in place can be, if you want time off, which during the pandemic, I've had a great excuse to just stay home and not go anywhere. Especially getting this implemented, you know, you want to be able to find somebody that is the right fit for not only like the patients, but the surgeons. So, you know, your liability, a lot of times you can substitute them in, but you check their policy. But I love the fact that I really can say yes or no to things. And, you know, the surgeon's like, well, if you need time, you know, we'll find somebody to cut. But I feel very like committed, you know. Over, I would say with 30, maybe 30 hours a week, if you average it out over the year, you're looking over 300 for sure. That's gross. So there's business expenses. They're not massive. There's not a lot of overhead. So I don't have employees. I pay my contractors. And before I forget, I think it's really critical to mention to people, talk to an accountant that's good, that this is the first year I've elected this past year an S Corp. If you don't know what that's about, you need to do some research or education, because when you go from an employee mindset to an employer or self-employed mindset, there are so many ways that you can do tax deductions legally following the tax code, and actually makes you understand why people out there can like not pay as many things in taxes.
It's insane.
Because you are providing, I mean, in essence, value and potential work for others. I mean, the employees get real bitter when they hear people not paying as much in taxes, but there's a reason. You're taking a lot of the risk, a lot of the headaches, and a lot of the things that people don't understand as an employee unless you live with someone or know someone well that does this. But my lifestyle is so much better, super grateful, but I feel extraordinarily committed to staying healthy and not getting sick and not being out, and make sure my surgeons are covered, and that I deliver on the promise to my patients that they're getting who they already met beforehand. So, you know, that's my biggest challenge, is just trying to make sure I can create some time away. But I think that's probably the hardest thing. You don't really have sick leave, and you don't have the vacation built in and paid for. You just have to accommodate for that based on what you're making on times you're working. So.
And that is the dilemma of being self-employed.
Yeah.
I mean, in everybody, if you're self-employed and kind of in that eat what you kill sort of model, that's what it is. But the return that you have is better tax benefits, and like significantly better tax
huge
benefits.
Tax savings with an S Corp.
You can set up your own retirement plans, and because you're self-employed, you can actually put a heck of a lot more than people can often do, because you can structure it in the right way. And then lastly, which in this day and age of decreased autonomy, you have autonomy. Like, I mean, again, you're kind of still beholden to the surgical schedules and things, but I could see that this is much more of a partnership rather than something else. So
yeah,
very cool.
Yeah. Well, thanks. Yeah. I'm quite, it's evolved over this last year and a half, but, and I can fine tune it here or there in different places, but I'm very happy and glad that the patients have enjoyed it and the surgeons appreciate it. And ultimately you want to feel like what you're doing makes a difference and providing something maybe a little bit more than what people expect. So.
Absolutely. Well, I'll take it out unless you have anything else that you want to say.
No, but I like that whole direct anesthesia practice terminology you put together there. So.
Direct anesthesia practice. Well, and I just kind of to roll this up. This is an epitome of a Change Physician episode, because what you're basically done is you have crafted a life that incorporates what you love about medicine in such a way that you can deliver care now that is also congruent with your values, and you have a great life. You know, the physician reimbursement is so far all over the place, and I'm just like astounded, like at what people are getting paid versus not getting paid. But when you're looking what you said for the 30 hours or so of work that you're doing, and you don't have any call, which is sort of the bane of most physicians' existence, that's pretty good. And in a practice style that, unlike many, is conducive to large metro areas. In fact, is really conducive to large metro areas. That's pretty awesome. So thank you for sharing what you do outside of the change physician with the listeners today.
Well, thank you. Yeah, and just so you know, I didn't include the pre-op time for the extra time, but that to me, that's stuff I do almost for free anyway. It seems like I enjoy it too much.
Okay, so you go from 30 to 35 hours.
Okay,
Ish.
yeah, roughly.
All right, and because of those pre-ops, now you decrease stress, and as we talked about in that other episode about that, it increased the value with the surgeons. So now you have a tighter relationship, so that they're more interested in keeping with you. So yeah, folks, great. If you're an anesthesiologist and you are looking for a change, I would highly listen to this episode again. Listen to episode 163. Maybe talk to Melissa if you're interested in learning more. And I think that's it for now.
Yeah.
All right. Well, everybody, thank you for joining us for an episode of The Change Physician. This is your host, Dr. Kevin Cuccaro, with my Amazeballs co-host and entrepreneur, Dr. Melissa Cady. If you are interested in learning more about the community or want to contact us directly, just go to thechangephysician.com. And until next time, stay well.
Take care.